Neurobiology here. I have a lot to cover, I'm going to start off with a very simple general statement. With increased awareness of prostate cancer and modern screening, men are increasingly diagnosed and treated for the disease when they are largely asymptomatic. As such, any long-term suffering they experience will more likely be from the side effects of the treatments than from the disease itself. Now, in terms of androgen deprivation therapy, approximately half of all men who are treated for prostate cancer will be on androgen deprivation therapy at some time during their treatment. For the next few slides, I'm going to flip through very, very quickly. There's introductory and what are the side effects of androgen deprivation, when it's used, and so forth. But I'm going to take it as a given that most of you know that, but it's posted on the website, so you can all look it up if you'd like. The primary treatments, one of the reasons it's so commonly used now is it's neoadjuvant to radiotherapy, but it can also be used as an adjuvant therapy for this positive nodes or positive surgical margins after a prostatectomy. And of course, it's used with this biochemical recurrence and metastatic disease. How common is ADT? This is astonishing. A number from Matt Smith at Harvard is that approximately 600,000 men in North America are on ADT at any one time. Minimally 40,000 of those men start on it long term. And of course, that's an easy number. I pulled it up because that's the number that are going to be diagnosed and die of the disease, and they're all going to be androgen deprived. So that's a very low number, actually. Despite moves towards active surveillance and intermittent ADT use, a lot driven here at Vancouver from your center here to get to intermittent use. And this is leading to a slight decline in the ADT use overall. There's a paper there from Crown out of Toronto which just documented that. Earlier detection results in PCA patients starting on ADT at a younger average age than in previous years. Some PCA patients may now be on ADT for 20+ years, and I saw documentation of that just recently. Someone who's on it for 20 years. So these learning objectives were to know what are the common psychological and social side effects of ADT when used to treat prostate cancer, to know the various interventions that can mitigate the psychological impact of ADT on prostate cancer patients, including ways to help prostate cancer couples maintain intimacy and a strong dyad in the face of reduced libido, and to understand the roles and needs of the partners of prostate cancer. So a big part of my talk is going to be focusing on why we, in the urological community, if I allow me to be considered part of the urological community, have to be concerned about the partners of the patients. Common forms of ADT, you all know this. Orchiectomies are not common here, but it's either through chemical castration. Estrogens were popular as oral estrogens, diethylstilbestrol. Now there's parental forms that are coming back into consideration. I'll be talking about that on Friday. I mentioned at the bottom here, long-term ADT equals castration. Now, we don't say that. We typically tell the patients they're on hormonal therapy. We actually, as an aside, have just done an online survey. We asked 600 cancer people on the internet looking for information on cancer. If their doctor recommended chemical castration for their treatment, would they approve it? If your doctor recommended hormonal therapy, would you approve it? It turns out that the patients clearly are significantly different in their willingness to accept hormonal therapy versus chemical castration. Okay, and it indicates that we're not telling them what hormonal therapy really is. So we typically try to avoid that. Both NDs and patients tend to avoid the word castration because of the stigma associated with the term. In North America, of course, we know that we use typically LHRH agonists, and it's the LHRH agonist side effects primarily that I'm going to be talking about, but they'd be the same side effects for orchiectomies. Now, the LHRH agonists are outrageously expensive drugs, the second most expensive class of drugs there are out there, and they have a slew of side effects. So that gets into what I'm going to talk about. And on this slide, I've got the list of the commonly recognized side effects, the ones that we worry about in terms of health-related quality of life, such as the metabolic syndrome, where you package the weight gain associated with LHRH agonists, plus the increased risk of diabetes and cardiovascular disease. You're talking about metabolic syndrome there. Osteoporosis, we're aware of, anemia, and so forth. I am going to be focusing on the features listed in blue there, such as erectile dysfunction, hot flashes, loss of sexual interest, and including ones down at the bottom here on the other side, increased emotionality and tearfulness, distress of loss of identifiers of masculinities, and such. Now, in this, the psychosocial side effects have been packaged. I listed them there, but they've been packaged differently. And there's a paper, a review article, with lead author was Stacey Elliott, who's here in the audience here, published last year in Journal of Sexual Medicine, which packaged these side effects into 5 categories, and I'm going to hit them all in the next few minutes. Body feminization, changes in sexual performance, cognitive and affective symptoms, relationship changes, fatigue, sleep, and disturbances. And there's the reference at the bottom. If you guys want to go online, you can dig up the reference. So let's take feminization of the body. Loss of body hair, often seen as Trivial, obviously it has little or no medical significance, but I'll come back to that in a minute. Loss of muscle mass. Estimates are approximately 4% with concomitant loss of strength and endurance. Increased weight and largely is body fat, largely is put on in the abdominal and the hip region. I mentioned Matt Smith from Harvard. He talks about patients who grab themselves. When he says, "How are you doing?" He's like, "Grab like this," and he says, "I can't. I've got this," and he calls that a positive Lupron sign, which I think is an excellent term. Some gynecomastia depends on the drugs used, more so with estrogenic compounds than with LHRH agonists. It depends on the drugs. And this is one that gets no attention. Nobody's even looked at it. Altered or reduced body odor. Now, we're more and more understanding that we as humans are olfactory organisms. Sexual preference, sexual acceptance. For women, for instance, the smell of males fluctuates with their menstrual cycle. If there's a change in olfaction, this could be affecting the dynamics of a couple. This is very likely. Anecdotal evidence supports it. However, it's totally uninvestigated. I want to take two of these features and point out that how important they are may be different in the mind of the doctor than in the patient. So, taking the hair loss, the body hair loss, patients vary greatly in the interpretation of such physical side effects. Indeed, it is often assumed that hair loss is a trivial matter of little consequence, but that gynecomastia may be devastating. However, it can be the other way around. Patients are often more bothered, by the way, if we deal with gynecomastia, than with the sensitivity of the nipples, not the size of the nipples. So that's something to be considered. Now, I know of no valid questionnaires, although it would be easy enough to develop one, which helps us decide which patients are going to be most whacked by which of these side effects. But I'll give you one anecdote. At a meeting, I went up to a patient I knew, and I said, I see you're back on ADT. And he said, "Well, how do you know?" I said, "Well, you don't have any hair on your arms." And he said, "Hey, I never noticed that." I have similarly, on the internet, saw a patient who was ready to sue his doctor because he lost his body hair and thought it was malpractice that he wasn't pre-informed of that. So it makes a case, there is a case for us to try to decide ahead of time who's going to be bothered by these effects and who's not. Moving on to the sexual side effects. With long-term ADT, you get testicular and penile shrinkage, impotence in greater than 80% of the patients, probably 90% or more, and reduced libido. More than 50% of men who are treated for localized prostate cancer by surgery, radiotherapy, brachytherapy, whatever, have residual EDT. Now, only about 1/3 find Viagra and other drugs in that class fully effective. And this number varies a lot. Well, I just saw one recently which says that 1/4 of them, not 1/3, will find the drugs effective. Low libido is an issue I'm going to come back to. Okay, on that list from the Elliott Al paper I had, item 3 was cognitive and affective symptoms. Depression, commonly reported but not well documented in controlled studies, and admittedly hard to separate from the grief of having failed primary treatments. Cognitive effects, and I'm going to spend some time with this. One of my favorite papers, tiny study, intriguing, was by Tom Beer down in Oregon. Verbal memory is significantly, this is a quote, verbal memory is significantly worse in patients on ADT. And as an aside, there's evidence that this can be reduced or reversed with transdermal estradiol, but this has not been replicated in larger studies. And that's definitely worth following up on. I'll be talking a little bit about that on Friday. Note, there is some evidence that the intensity of both of these side effects, that is cognitive and affective side effects, may be in part age dependent. So there's about a slew of papers in this area on cognitive and affective stuff, and they're coming up with very different answers. Shabir Alabai is a gerontologist out of Toronto, publishing a lot in this area, and Shabir doesn't find a lot of cognitive effects, but he's working with an older population. None of his patients are under the age of 66. If you look at the younger patient, you get a different answer. So age may be an important part. And other psychological changes are not so rigorously defined. Concerning depression, depression is often associated with low testosterone, so that's a classic sign of hypogonadism. In PCA patients, it may be linked as well to the anxiety associated with disease progression. A small paper published here in Canada by Dalhousie and I'll reported, quote, a 3-fold increase between rates of pre-ADT psychiatric illness and development of a de novo illness after starting ADT. So it was a jump from 9 to 29%, and most commonly was in depression, with 56 of the patients reporting depression. I know one oncologist who simply, if he puts a patient on ADT, puts them on antidepressants automatically as a standard practice. More on cognitive and mood effects. Significant changes in self-rated mood, such as increased depression, tension, anxiety, fatigue, and irritability were evident during ADT treatments. This is from a paper at the bottom is cited there, and I think many of you probably know T. Hagano from down in Washington. She's the senior author on this paper. I quote another quote from this paper. ADT may result in some adverse changes in cognition and mood. However, many, but not all, that's my emphasis, of these changes can return to baseline after cessation of ADT. So we put patients on ADT, say as neoadjuvant to radiotherapy. We say it's short term, you're not being castrated, you may be a little depressed, but you will get over it when you go off the drugs. And this paper suggests from their studies that they may not recover baseline status. So this is really profound and something that the patients need to be at least warned of. ADT, some more quotes from that paper. ADT patients evidenced a significant decline in spatial reasoning, spatial ability, and working memory during treatment compared with baseline. And I'm making this statement here. Both physicians and patients, plus their partners, should be aware of how this may manifest itself in everyday life. So how many patients understand what spatial reasoning means? How many of the physicians treating them understand what working memory means? And I'll give you that I will assert right now that these features are affecting performance in absolute everyday situation. So the patient is trying to remember where he left his car keys. He tries to remember the path he's traveled, okay, and he thinks that he must have left him in the living room. That would be an example of spatial reasoning in everyday life. He goes into the living room and can't remember why he went into the living room. That's an example of working memory. So in practice, these are real features that affect real performance in everyday life. The bottom line on cognitive decline is that between 47 and 69% of men in ADT experience a decline in at least one cognitive area, most commonly in visual spatial ability and executive functioning, same as working memory there. ADT is linked to subtle but significant cognitive declines in men with prostate cancer. Now, this paper by Nelson, Christian Nelson, is out of one of the best groups that's working in this area, and that's at Memorial Sloan Kettering. This is an excellent paper, and I quote from them again. The authors believe that clinicians should inform and monitor patients for the possible side effects of treatment. So you might ask your colleagues, how many people are putting patients on ADT and monitoring the psychological side effects? Moving on to emotionality, that is mood issues, affective displays. Changes in emotionality have been repeatedly reported for androgen-deprived prostate cancer patients as well as male to female transsexuals. I've done some of the work in that area. Most conspicuously is an increase in tearfulness. Now, in our society, women may cry, may be seen as a sign of empathy, but men crying is seen as a sign of weakness. Real men don't cry. So an increased tearfulness can be thus embarrassing to men on ADT, and one of our studies showed exactly that. A patient was terribly upset because his teenage son had seen him crying. The American Cancer Society says the following, and I think this is a terrible quote. I think this is almost unethical to have this in there, but men who no longer have their testicles or who are on hormone therapy drugs often feel like, quote, less of a man, close quote. This is a man. There's a grammatical problem as to what this refers to, but they go on to say, and this is their bold, not mine, manhood does not depend on hormones, but on a lifetime of being male. And I give you the source of that quote there. What that is saying is that how you lived your life makes you masculine. That's fair enough to say. This is sort of a socially constructed idea. But it is also true that if you are, say, 70 years old and you've had more than half a century of nocturnal erections and common erections, then that's how you live your life. And if you've lost the erections, then you've lost something right then and there. This presumption, I'm quoting from the statement from the bottom, this presumption that the male gender is first socially constructed and then invariable sounds reassuring, I suppose, if you don't think about it. However, many studies have shown that the psychological consequences of impotence alone are severe and exacerbated by the common male response to illness and disease, which is to suffer stoically and silently. Additional cognitive, affective, depressive, and emasculating side effects of the ADT don't help. Overall, ADT typically leaves patients impotent and depressed, and is shown in many studies in the last 2 decades with serious reduced quality of life. So, staying with that about the maleness of these patients on these drugs. ADT often challenges men's core identity, leaving many feeling like they're at the border of masculinity, not fully masculine or feminine, but undefined. And in the sociology literature, there's a quirky term for this. This would be a liminality. They're in a liminal gender space. And there's a paper here by Navon and Morag, which has the weirdest title. which no urologist I don't think would ever understand or read. Liminality is a biographic disruptor, unclassifiability following hormone therapy, but it's actually an excellent paper. And independently, John Olive, who's on this nursing faculty here at UBC, has come up with basically the same results. There's a quote here from a patient at the top from another Navon and Morag paper. They were in Israel doing this work, which talks about how he feels like he's changed. He's not quite the male. He looks at himself in a mirror and he's upset. I'm not going to read the whole quote, but I want to say the following. Similar quotes from prostate cancer patients' reaction to ADT can be found in 6 qualitative studies published by research groups in the last 8 years from Israel, Australia, England, USA, and Canada. And I was a co-author in the Canadian study. So what we're saying here is testosterone does, in part, make the man. Now, relationship changes. This is really where I want to focus. Faced with such changes in their lives, many men, 1, withdraw their affection from and physical contact with their partners, and are embarrassed by the changes they've experienced and are reluctant to discuss them with their partners, which leads to depression and frustration in their partners. So we now have an epidemiological iatrogenic problem. Okay, the doctor puts the patient on ADT, and the partner is now whacked. And this is from a paper, the nicest paper in this area, by the way, I think is one by Soloway. This is Cindy Soloway. Mark Soloway is a co-author, her husband, on this paper. It's an excellent little paper. The cost to the partner. Studies going back, this isn't new stuff, I'm telling you. Everything I said has been there for a while. Studies going back to 1994 show that the psychological distress on the partners of prostate cancer patients is even greater than that on the patients. So if you're worried about the patients, the partner is even in worse shape. Withdrawal of intimacy in general, not necessarily loss of coital sex, seems to be the biggest problem. So this is a paper I'll come back to in a minute. It's an excellent one. I'll cite it again. Hagendorn did a meta-study and shows that basically when there's a cancer diagnosis in the family, a female will be more distressed, whether she is the patient or the partner, than the male. Males use denial. Effectively, the women do not. And that gets to the communication problem. Critical factors explaining a spouse's greater distress include the discordance. This is a quote from Kornbluth. This is the 1994 paper out of Sloan Kettering. She's moved to Harvard now. But this is an excellent paper. Critical factors explaining a spouse's greater distress include, quote, the discordance in communication between partners with the spouse needing an open discussion of disease-related feelings and problems, and the husband needing to minimize the effects of the disease with little desire to have an open discussion. So she's stressed. She wants to talk about it. That's a standard thing within the gender stereotyping here. Women like to talk about their problems. He's got a problem he can't solve. He'd rather deny it. This is not going to lead to good communications. Loss of intimacy. By the way, if there's one slide I want to take-home message, it's going to be the bottom of this slide from that Kim et al. Paper that I mentioned. I showed the reference to a few slides back. Women may perceive a lack of emotional mutuality or reciprocity. She's approaching him, wants to be supportive. He wants to deny that anything's wrong. She may interpret this as emotional abandonment, and women may interpret this as their own deficiencies in interpersonal sensitivity, which leads to feelings of isolation and social inadequacy, and thus poorer mental health. So she tried to help him, and he's withdrawing from her, and she's really hurting. Now, this paper is brilliant. Distress in the partners correlates with the distress in the patients. Namely, there's evidence, quote, evidence of partner effects, at least from women. That is, a woman's distress predicts a man's physical health over and above the man's distress, age, and cancer stage. That is, her distress level is an indicator, probably the best indicator we have, of how he's doing, even if he's saying, I'm doing fine in the doctor's office. And he may be fooling the doctor, but he isn't fooling his partner, who he's been married to perhaps 30 years. She knows how bad it is, and her level of distress is an indicator of how he's doing. So we need to worry about the partners. And for some reason, we're clipped off the bottom of there, but this gets into sleep disturbance. This gets to item 5 on that list from the Elliott et al. Paper. Moving on. Sleep disturbance can be associated with insomnia, relating to daytime fatigue. So I'll be talking about estrogen and sleep disturbance in castrated males on Friday. The insomnia is probably in part related to nocturnal hot flashes, which may or may not be cognitively registering, but are disturbing sleep, which can lead to fatigue. So fatigue, sleep disturbance, depression, these all come together as a trio of symptoms, and they're common in many cancer patients. And as an aside, if they are present in the cancer patient, the insomnia alone could be waking up the partner, so she can become fatigued as well. When ADT is administered for disease progression after failed treatment, and a curative treatment is no longer an option, this treatment, I don't know why that's clipped, this trio of symptoms is not a surprise. Okay, I'm now at a sort of a breaking point. I'm not going to read these, but these are the 3 learning issues, and I will assert that I've covered the first 2. And now it's all very well and good for me to stand here and tell you how bad it is for these patients, but that's not any help. We've got to come up with something to help them. So from here on, I'm going to talk about interventions that can mitigate the psychological impact of ADT, and I think that's a responsibility we have to try to find solutions, not just to list problems. What can be done for the patients and their partners? So a goal of my research is to explore options that go beyond standard treatments for ED, which are too often ineffective or unacceptable for many patients, particularly those on ADT. That is, Viagra doesn't work in this population. Since the side effects impact both patients and their partners, addressing these side effects is an issue for couples, not just individual patients. Since the physical and psychological side effects interact, they need to be addressed concurrently. So some of this stuff is standard practice. I've already, up the top there, I mentioned the use of antidepressants for mood. I simply say SSRIs. Other antidepressants can be, plus exercise can help mood. SNRIs, particularly, Effexor seems to be a good one for helping with hot flashes. There are other stuff that gets some attention, acupuncture and so forth, but this is sort of the standard way to go. Now, admittedly, those will have sexual side effects which don't help in that regard. The single best documented intervention for most ADT non-sexual side effects is exercise. I'm going to say a few minutes about that. Categorically, I would say that again, I'm not a practicing physician in this situation, but I would say to a patient, look, we can help you with this drug, but I need you to start an exercise program now, come back in 10 days, show me what exercise program you're on. If you're on that program and you're taking it seriously, I'll put you on these drugs. I mean, that is, make the exercise program part of the treatment program. Transdermal estradiol can help with mental acuity, I would argue, at least from the Tom Baer study, and plus the menopausal symptoms, which are hot flashes, osteoporosis, and possibly libido. However, it increases gynecomastia, chemistry, so I'm not going to say too much about estradiol now, but I'll save all that for Friday. I want to say a few things about exercise, though. Absolutely, 1, it's the best thing we can do is get these guys on exercise. 2, we have to be realistic about what we can do. 9 studies have been published on exercise as an intervention for managing ADT side effects over the last, I guess it would be 8 years. Collectively show that muscle strength and endurance most assuredly is positively affected. That is important. Cardiovascular fitness appears to be positively affected, but there haven't been a lot of studies that have run long-term enough with large enough sample sizes to show that. Weight control. Every one of these studies, not a single one of them mentions it as a key finding, but when you put them all together, it is a key finding. Not one of them shows any effect on weight control. That is, the ADT, given our Western diet, is going to lead to weight gain, and telling these guys to exercise just doesn't, with any reasonable exercise program, unless they're a marathon runner, is not going to get them weight control. And I think that's an important point. Fatigue and depression, most of the studies show positive effects there. So here's a clinical counselor advice I'm offering you. Do not advise your patients to exercise to avoid weight gain on ADT. It will do no good. Instead, it sets the patient up for failure, which can lead to additional depression. Now, back to the impact of ADT on sexual function and side effects. What do we know? These are grim facts. 50% of PCA couples stop using ED treatments within a year, even when the treatments work and the patient is not on ADT. So either we're not measuring erectile function properly, or there's something going on here. We have all of these treatments, and we all know how serious ED is as a problem because no disease has ever gotten more attention from the advertising industry. Nothing, not malaria, not death in childbirth, than erectile dysfunction. Because if you watch the TV ads, that's what you see. None of them tell you that most people give up on these treatments. About 50% of the patients give up on these treatments within a year. Loss of sex life is the most distressing long-term side effect of PCA treatments for patients. Loss of intimacy of both a sexual and non-sexual nature is a loss for both the patient and the partners. Now, I have heard a naive, I would say somewhat offensively a naive comment from a practicing MD. Well, I find that my patients are no longer worried about ED when I go on AD. About ED, they're no longer worried about ED when they go on ADT. That is, they lost their erections, but now they've lost their libido, so they're no longer worried about it. I asked him whether he had bothered to ask the partner about this. These are 2 separate problems, but they're both severe, and just losing your libido doesn't compensate for having lost erections. Lastly, and this is a tiny study out of Israel, approximately half of all couples on ADT experience some erosion of distress in their spousal relations. So 600,000 couples, or 600,000 guys are on these drugs at any one time. Half of them may be having family problems as associated with that effect. What can we say about depressed libido? Most men on ADT experience nearly complete loss of sexual interest and the ability to have orgasms. And my approach has been not to focus on that, but to focus on the very few who do retain function and ask, what are they doing? Okay, what's different about them? This is worthy of much more study. 15%, however, still report being sexually active at some level and are capable of having orgasms even without erections. So who are these sexually active men? And key factors are likely, not formally investigated. Well, partially we know this already for age and general health status, but clearly age, general health status, and motivation are going to be factors. And it's worth noting that, for instance, voluntarily castrated men, such as male to female transsexuals, are not uniformly asexual. A couple of years ago, a medical student, he's now a practicing physician, Michael Coyne and I did a historical review, and this was intriguing to me. I mean, looking at eunuchs, castrated men in history. Historically, not all castrated men were celibate nor sexually inactive. Eunuchs in the Roman antiquity, early Islamic societies, and during the castrati period in Europe were known to be sexually desired as partners and even considered lascivious. Eunuchs married women in both Chinese dynasties and the Ottoman Empire. Moving on, the amount and type of sexual activity of modern-day castrated males varies greatly. For example, if you look at sexual predators who were elected to go on LHRH agonists, or if they were in Texas, a surgical castration, less than 7% of voluntarily castrated sex offenders, a procedure permitted in 14 U.S. states, become recidivists, a group highly motivated to be asexual. That number is high. Studies from Europe put it below 3%. Many castrated male to female transsexuals, in contrast, are known to be sexually active and work in the sex trade. In an internet survey that we did, a colleague of mine who's an anthropologist, of voluntarily castrated modern-day self-identified eunuchs in the Western world, only 4% consider themselves asexual. So asexuality is not an obligatory aspect of ADT in every single case. And modern-day eunuchs in India, this is a sect, the Hijra, are active in the sex trade and some also married. So the big question is, how is sex possible if you are impotent and have low libido? Oops, let me cover this. Okay, so what do we offer? What can we offer patients in general? We have ED treatments. All right, so ED treatments, and I would argue that the ED treatment is a phallocentric or a male approach. The goal is to recover previous capability for penetrative sex. This is what most men want and what is regularly offered men. And here's the catch about ED programs. ED treatments that are not 100% effective can exacerbate a patient's sense of loss, making things worse, not better. So, I mean, I've already told you that 50% of people stop using them after 1 year. People haven't been studying that. I think we need to be studying that and understand why. The alternative option that is given them largely is accepting a non-penetrative sexual practice, oral sex, mutual masturbation, or whatever. This is acceptable for some men, but still a loss if penile vaginal sex remains the man's gold standard for sex. I'm going to introduce a third approach. That's neither of these, neither the male nor female, but other, renegotiation of sexuality. Before I do, I want to point out the sort of books that are in the market. I'm intrigued by this. So the real popular book now that's getting a lot of press is by John Mulhall out of Sloan Kettering, titled Saving Your Sex Life. Male author. This book is not about saving your sex life. This book is about erectile dysfunction. Now here are 5 other books which discuss this couple had discovered oral sex, they discovered mutual masturbation. These books all talk about how you can still have intimacy if you have impotence by cuddling. Now, basically, every one of these books takes the female approach, and every one of these books has either female authors or co-authors. And this is the only male-authored book, and it takes the erectile function approach to this issue. Well, there's problems with both approaches. Alternative sexual practice. A third approach is the use of a mechanical sex aid, which is an alternative to both 1, imperfect ED treatments, which may be what you deal with a male approach, and 2, the acceptance of non-penetrative sex, which I've simplistically labeled the female approach. The option 3, however, is rarely presented to patients in ED treatment programs, nor actively explored by PCA couples, for it is neither a strategy for sexual recovery, nor acceptance of non-coital sex, which would be the female sort of the model as I've gendered it here, but rather the acceptance of a new sexuality. And note, couples that discuss such options, okay, may be able to maintain, even build intimacy for both a sexual and non-sexual nature. So what we're saying here is that there are alternatives to either trying to recover the male function, accept a female functionality, or there are ideas that I'm going to just talk about in a second. Okay, and if you can get couples to even talk about them, then you can actually help rebuild intimacy, even if they don't go anywhere with it, because they're sharing something they not share with anyone else. So what are we talking about here? In the medicalized language of Ross Gray and Laurie Klotz, option 3 includes, and they published one paper listed at the bottom there, use of a belted prosthetic phallus. a term they made up, which does not depend on penile erections. It allows for insertive receptive coital sex. And I apologize for the language here. We have two choices. We have a belted prosthetic phallus, which is not clear to anyone because it's made up jargon, or we have the street lingo, which a little bit sounds crass to deal with, but we're talking about a strap-on dildo. I'm going to talk about the biomechanics of that in a minute. There's been 3 papers of case study Nature published on this option, and it hasn't caught on because nobody's testing it in any clinical setting, which is something I'd love to see us do. Some physiological considerations. Sex with a strap-on dildo, that's with a leather harness and a plastic phallus, allows for natural full-body contact, a natural embrace, and normal hip movements. Such movements are difficult, if not impossible, with incomplete or hinged erections, as typically occurs for patients using ED treatments that are not 100% effective. In the working et al. Paper, which was listed in the last slide, the patient was on ADT and reported that his partner, he'd thoroughly castrated. Testosterone measures we have on the patient, and they would crash. I mean, he's at castrate levels that he'd been there for I think 6 years in the date of that paper. I can go back and look at it. But the partner held his penis with her hand during dildo-vaginal copulation, and mutual orgasms were achieved. This can be partially explained by the fact that a penis that is wet, warm, and tactily stimulated does not care where it is. But note, however, it was his hip movements that determined the penile stimulation. So she's not masturbating him, she's just holding on, but as he moves, he's getting the stimulation that he would normally get if he had normal coital sex. I think what's also going on here is an example of what's called the rubber hand illusion. And this has been well documented. This is the first paper, and this is published in Science, in the Nature Science Journal. If you take a prosthetic hand, you put it under a table, and you put it on a table in front of a person. You take your real hand under the table, they can't see it. You touch their hand in a very specific place so they feel it. While they see the prosthetic hand being touched in the same place, they get a multi-sensory integration. It looked right and felt right, and they announce that's my hand when they see the prosthesis. And our patient reported essentially everything about this copulation with a dildo, even though it wasn't his penis and her vagina, felt so natural to him that he was able to achieve orgasms. Now, the group in Sweden that does this work has gone on to show that it can be tactile. It doesn't be visual tactile. So here you have the subject blindfolded. The investigator is touching with the subject's left hand on the prosthesis, while the researcher touches the patient's real hand in the same place. And then asks the patient, are you touching a rubber hand or your own hand? She says, I'm touching my own hand, even though she's not. They've gone on to even go further with this. They've done it with full body. You can actually, the mannequin has TV cameras, the subject is wearing TV goggles. They poke his stomach, and the person reports that the mannequin's body is his body. So multi-sensory integration here, I think, is an important real part of why this dildo option actually can work and beats probably any ED treatment that isn't 100% effective. But it needs a lot more investigating. When ED treatments aren't perfect, okay, and I'll consider, for instance, a vacuum erection device, which is a fraud. And because of the word erection, you'll see what I mean here. In Saving Your Sex Life, that Mulhall book that I mentioned before, he says, Mulhall, that the most significant disadvantage of the device is that it generates a non-cosmetic erection, one that does not appear pink. A far bigger problem is the hinge effect, due to the fact that the root of the penis is inside the body and cannot be engorged with blood with a VED. The result is that the penis acts as if it is hinged at the body wall, and the hinge effect does not, this hinge effect, I want to point out, would not occur with a prosthetic external phallus, such as the strap-on dildo. Now, with imperfect ED treatments, the penis may be enlarged, firm, but will not be erect. I'll come back to that posture issue here. And I think it's a big problem, because if you look at something like the IIEF, our Index for Erectile Function, one of the marks of success is firm enough for penetration. Was it firm enough for penetration without somebody having their hand to hold it and insert it? Or was it, that's could they have normal embraces, or do they actually have to be hand inserted? That type of information is not provided. Okay? And what really happens if you look at ED treatments, the last thing that the penis does as it becomes more and more towards a higher number on the IIEF is gain its proper erect posture. So if we don't have we don't have full erection, we're going to lose that. All right? Having to adjust posture to remain in copula, that is without a complete firm erection, distracts from the naturalness of coital sex and inhibits orgasms. Many couples give up on the VED and other ED treatments that aren't 100% effective, yet never know why they don't work. And this is a tragedy, because what happens if this hasn't been explained to the patients is she feels she moved wrong, he feels he moved wrong, something happened, and they're demoralized and discouraged, they don't want to try again. Okay, so one of them withdraws from the other, or they both withdraw. It's a tragedy. An ED treatment that is not fully effective, but only partially effective, can do more harm than good. It can erode a patient's confidence and a sense of virility and masculine capability. We need to be explaining the hinge effect. So here's an example of what I mean about the erect nature of the penis. This is, by the way, a couple having sex in an MRI. This is their body wall here. Here's this penis in her vagina. Here's the root of the penis. Here's their wall. So you get a hinge effect right there. But notice in normal coitus, that's erect. The orientation is not quite fully vertical, but it's not hinged at the body wall. And by the way, as an aside, Leonardo da Vinci attempted to draw that. That would be the penis. This is supposed to be the female over here, male here. Now, how successful is this option? The strap-on option is now being cautiously offered by counselors in Halifax, Toronto, and Calgary. These are my collaborators, to some couples who are dealing with the impotence. Some of these couples are willing to try it. Some of the couples that have been willing to try it found it gratifying. For couples willing to explore this option, such sex play may rebuild intimacy even if one or both failed to achieve it. So one of the nicest reports I got back from a couple is, well, it really didn't work for us, but we never laughed so hard in our life. And I consider that a success, because they just shared something they're never going to share with anyone else, okay? And it built intimacy. So it's, I think, important to offer this to them, to give them that option. More research is necessary to find out for whom this end run around ED treatments is acceptable and effective. Now, my colleagues in Calgary, this is Lauren Walker and John Robinson, pointed out, and they're in a separate study, was part of Lauren Walker's master's thesis, that couples often assume that sex is to be impossible after commencing ADT. However, their study showed that, confirmed that some couples are able to enjoy satisfying sex despite castrate levels of testosterone. Furthermore, they suggested that the couples who continue to struggle to adjust to ADT may have fared better if they had known how other couples are able to maintain satisfying sex while the man is androgen deprived. So we need to be telling couples that it is possible to be sexual on ADT, because if they all believe that they're not going to be sexual, there's nothing like expectation of either sex or non-sex to be a turn on or a turn off. So we should be telling them of this option, and I think that it would be helpful. Introducing the sex aids. There's a really big issue here. How do you introduce this stuff to patients? We really don't know. How do you make this acceptable? Patients and partners need explicit instructions about options for alternative sexual practices. It's not good enough to hint at the idea. So if you're not comfortable using the word dildo, but you don't want to, you think you're going to tell them to go and get a belted prosthetic phallus, and they don't know what that is or where to get it, you're not going to be helping them. It is not good enough to hint at the idea of alternative practices, nor present ideas to one partner, not the other. Partners need information presented to them together, as they both need to be on board for trying new sexual activities and aids, and to make sure nothing gets lost in translation. ED treatments that are provided to the male in the absence of the female without her buying in are useless. The counseling challenges here are great. They include encouraging both partners to be willing to explore new ideas as a couple. So obviously, they both have to buy in on this, to explore this, and giving the couple detailed information in an acceptable way. And we need to be doing a lot more of that. I'll give you an example here. Stimulation to orgasm for impotent patients with low libido typically requires extra tactile stimulation. So I am an anatomy professor. This gets back into my sort of territory here. And of course, recognizing that orgasms are possible without erections or penile coitus. With ED, with erectile dysfunction, penile stimulation will need to be longer and firmer to reach orgasm. It is harder to stimulate cutaneous nerves in the penis if it is flaccid. But if there is no option for erection, then to adequately but safely stimulate those nerves without abrading the skin of the penis, a lubricant, and these are some products, Astroguide, KY, Silicone, they are available in drugstores, or a similar product is essential. As an aside, the first time I even talked about this topic was at a prostate cancer support group in one of the big hospitals in New York City. And afterwards, people were coming up to talk to me afterwards, one at a time. And this guy who has an Orthodox Jew with a yarmulke is in the line, and I'm thinking, oh God, what is he going to say? I just talked about that dildo. And he comes up and he says, you know what you said about masturbation? I use talcum powder. And that's what he wanted to inform me of his option for this. So it's hard to know how and who will accept these type of things. But what is clear is that patients need very specific information. So do they know they know this stuff? Do they understand that they're going to need lubricants? In nature, of course, with coital sex, the female body provides a lubricant. Okay, but we're not dealing with that here. So relevant questions about lubricants are both partners familiar and comfortable with these commercial products? Have they used them before? Do they understand the need for lubricants? And do they know the names of reliable products, which ones are best for males or females for vaginal insertive use, where to buy them, etc.? And if they don't, then it's a deal breaker right there. More on strap-on sex, the prosthesis. This has been growing continuously since the 1980s within the lesbian community. And I would argue that this is because of its effectiveness. allowing for multi-sensory stimulation and integration. So there's more to sex than just the penis and the vagina. There's the body wall, the head, the sounds, the position, the grasp, the embrace, all of that. And that can be all normal with the strap-on, even though it isn't actually his penis, it's in a vagina. So getting all that as multi-sensory integration can make this work. Okay, for the couples, the embraces, the body orientation, head position, hip movements, etc., are virtually identical to normal penile-vaginal intercourse. And this can be used effectively with either the male or female on top or bottom. That is, if postures aren't going to be a problem. Can build confidence since there is no risk of loss of erection and little risk of premature dildo-vaginal separation. There's no hinge to worry about. And to go beyond heterosexual normality, if we're dealing with gay couples, either the patient or the partner can wear the prosthesis. So that's an option as well. I'm getting into the home stretch here. Give me just a few more minutes. The idea of starting with the least, this is what we deal with in ED treatments. The standard thing is we'll start with the least invasive. Try the Viagra. If it doesn't work, we'll move on to VED or we'll move on to penile injections. The idea of starting with the least invasive and working toward the most invasive treatment in a stepwise fashion means that failures become cumulative. After a man has tried 2 or 3 ED treatments that have failed, his morale, I will say his masculinity, is often compromised, and his emphasis and his enthusiasm for exploring further is diminished. Now, one solution here is to present more than one option at a time, to be honest and fully in what we present to the patients. I mean, to tell them, oh, well, you can still have gratifying sex by mutual masturbation after the guy's tried 3 ED treatments that have all failed is not going to work. I mean, that's not the way to do it. Explore with the patients and partners singly and together ways to eroticize mechanisms and pharmaceutical aids and ways to combine them. That's what needs to be done, I would argue. So general points of eroticization. In virtually every case where sex aids are found to truly benefit a couple, eroticization is at the core. Effective eroticization means associating the new object aid or technique with the sexual pleasure that the partner can provide. This is true whether we are dealing with something as simple as a little blue pill. And as an aside about this, how many stories have people heard about he tried the pill, he didn't tell his wife, it didn't work. But you hear that too often. It's becoming now a repetitive story. What it means is that he wants to pretend that he can reproduce his previous masculine effectiveness, functionality, okay, and not let on that he needed an aid. However, if she hands him the Viagra, okay, as a preemptive act where it works, okay, she's eroticized it, and he knows that then I'll make it work that much better. Effective eroticization means associating the new object with the sexual pleasure the partner can provide. This is true whether we are dealing with something as simple as a little blue pill or as complex as intercavernous injections. The arousal, and this is why I think the strap-on option needs to be offered, because the arousal for one partner that is linked to the aid can feed back on the other partner and elevate the level of arousal for both, as has been reported for strap-on use. And I'm on a prostate cancer intimacy list, and this was just reported about 2 weeks ago for a guy who had not had penetrative sex with his wife for a long time. She didn't hold on to his penis, but he used the strap-on for the first time. She got so excited, he got excited and had the first time, and I don't know, it was a year and a half they had penetrative sex. So this can be a turn-on if they both buy in. Here are our 3 learning objectives. I'm not going to read them over again. I want to say some, like 4 minutes, maybe 3 minutes. The willingness of couples to explore novel sexual practices may be influenced by the following. Previous experience with such sex play. I don't know whether they need to be doing it before or not have done it before in order to work. We don't know. Intimacy and spousal dynamics. Obviously, if they've had bad spousal relations and he goes on ADT, that isn't going to help. Comfort and commitment of both individuals to discussing options and the setting in which these ideas are presented. So Klotz and Gray suggested it would only be acceptable in the doctor's office using the white coat model. Workington et al. Suggest that it won't work in that way. It has to be really eroticized and part of sex play. All of these things need to be investigated. I'm running out of time, but let me just say, go through this one slide here. Not all PCA couples need psychological support, nor could the healthcare system ever provide support for all. Those who are sexually active or have problematic dynamics as a couple at the start of ADT appear to be in the most need, and also the population that can be most helped. Now, in a lovely paper, also out of Sloan Kettering, Mann et al. Showed that the partners with a higher cancer-specific distress, so the partners distressed, has lower marital satisfaction and lower intimacy. That is, if they're stressed out, what Sloan Kettering offered them is a 5-session couples therapy into program, and it worked. However, they buried in the back of their paper that the couples who were not distressed at the outset were actually worse off because they looked at all the problems. So we need to be able to sort the patients into who needs help and who doesn't. We need ways to, as I say here, to sort out patients and partners ahead of time into who is in the most need and who can benefit most from some counseling educational. Now, this is not complicated. This does not require urologists to go back and do 2 years of psychiatric residency. This requires, I think, probably questionnaires or 2 simple questionnaires. From my own look at this and the studies I've been doing with colleagues in Calgary, probably the 2 simplest ones would be the dyadic adjustment scales that looks at how they're doing as a couple, okay, and the brief index of sexual function, which is exactly that. It's very explicit. What are you doing sexually? What can you do? Okay, they can probably do the job. These could be administered by a nurse or assistant in about 10 minutes to patients and partners, okay, about to start ADT. And we could start to sort with who might we want to say you should have a counseling program and who shouldn't. And actually, we've been doing this. My colleague in Calgary, is John Robinson. We're just finishing down a Canadian Institute of Health Research project with this laborious title, Who Needs Help Most and What is the Best Way to Help Them? Developing and evaluating a preemptive educational intervention to reduce the psychological distress of ADT on patients and their partners. I won't walk through the whole structure, but let me say it's built around, we wrote a 70-page work booklet for patients and their partners about ADT, which is an educational booklet that's being, we set up a test where we randomized the patients. We looked at 2 groups, those that were sexually active and those who weren't. And one group we split them into sexually active and not, and got intermediate intervention, which was simply given the booklet and a 2-hour educational session to talk about their concerns and problems afterwards. That was all it was. Simple. One booklet, take it home as a couple, please both of you read it, come back to our session. And then the others got it 6 months later. And this is a profound issue here, because whether one goes with this or any other program, we're exploring here whether we should be telling the patients the whole truth about ADT at the outset. One could argue that we're going to scare the hell out of them. We shouldn't bother. Our data suggests otherwise. The patients are going to be better off looking at everything. These were some of the indices we used. Yes, I'll just say that what we can show, we're underpowered. It was a little pilot study. But those who got the booklet first immediately, okay, actually showed some improvement for it. Those who were sexually inactive and got it late showed no improvement at all. We have other data that sort of shows the same thing. Those that got the booklet early were more likely to stay sexually active, and don't worry about the details there. So this is a small sample size and underpowered, but what can we say? Early and comprehensive information on ADT appears to help couples adjust ADT. Information is particularly helpful to couples who are sexually active prior to starting on ADT, and the current status is that there's now a full-blown RCT underway in Calgary on this. Conclusions. ADT psychologically burdens. Got 1 slide left after this. ADT psychologically burdens PCA patients, often their partners even more so. The partners are concerned. Patients who are sexually active at the start of ADT are the most in need of help. Both the patient and the partners should be assessed before starting ADT, I would argue, and both should be offered some psychological support if needed. And a preemptive educational intervention probably can help, but it probably doesn't require much more than that. Orgasmic sex is possible for some PCA patients on ADT, and knowing about that possibility can help couples even if they don't explore such possibilities. So I want to end up with this final sort of piece of grandstanding here. As a last point, it is not enough to ask couples whether they think they might need psychological support to deal with the impact of ADT. In your office, a couple may elect to present themselves as a co-supportive team. If the patient says he is doing fine, his partner may then feel obligated to say the same thing. However, if you ask them individually, you may find that one or both of the individuals needs additional support, but was reluctant to admit that to you in front of their partner. Thank you very much.